try to answer people's questions. The first question is, will the 18 Fluorodopa PET ever be available to the general public? I would like to refer that to Dr. Del Rivera, who has personally seen more Fluorodopa PETs than anybody in the room. So why don't you give us your take on it?
Right. So we actually do have a protocol at the NIH using Fluorodopa for MEN1 patients, but honestly, I don't think it's better than the 6-day Gallium that they scanned. I think that we're using it to see if there's any difference. I don't think even if the tumor did differentiate, I don't think it will be better either than Gallium scan or FDG PET scan.
Okay, thank you.
What do you think?
I'll give you my take on this.
Yes.
I think it's an incredibly good test. And it shows things that are so tiny that sometimes they don't show up on a Gallium scan. So to evaluate sites of disease, I think it's fantastic. It doesn't bind to the somatostatin receptor, so it tells you nothing about whether you would be a good candidate for somatostatin receptor-based treatments like we've been talking about today. But for looking at disease, it's great. The problem is that you need to have a cyclotron and make your isotope right there, and it's very hard to make it generally available all over. And there are reimbursement problems. There was a time when they were doing it at UCLA. I don't know if they're doing it there anymore. I don't think so. I think NIH is about the only place.
Yeah, but at least for MEN1 patients near endocrine tumors, we have not seen any.
Right.
I don't know if there's any difference compared to sporadic, but we haven't seen that.
Right. So, but it is a very good test, and for those people who get it, it's a great thing. Okay, a great question. How many times can I take a PRRT treatment? It's a great question. Most of the studies that have been done have been with 4 cycles of 200 millicuries each, because the European studies that were done earlier on looked like there was excessive toxicity if you went past that total cumulative dose in one round of doing one treatment every 4 times. So that's usually the max, and some people can't even tolerate that much and have to stop after 2 or 3. But then the question comes up, what if somebody's cancer starts growing in the future? Can you be treated again? Retreatment. And it looks like you can retreat. Not everybody, but a lot of people who have good blood counts and good physiologic function. But you usually don't give 4 treatments if you retreat. It's usually only 2 treatments, which is a half dose. It's a total of 400 millicuries instead of 800 millicuries, but it does have effectiveness. But like all treatments for neuroendocrine tumors, you have to say, what are the benefits, what are the risks, what are the alternatives, and should that be done, or should the patient be on a different clinical trial, or should the patient be on something else, because you might cause some irreversible problems with extra PRT. I don't know how the rest of you feel.
I think that's very accurate. In this additional 2 doses of data, there's 2 more doses to make it total 6 coming from Europe. They've been always a little bit ahead of us in terms of radiopharmaceutical use in neuroendocrine world. However, we have to be very careful regarding the long-term side effects, especially the long-term nephrotoxicity and myelotoxicity, because there are some retrospective reviews from Europe again regarding myelodysplastic syndrome and leukemias developing down the road. So we have to be careful. You know, this is a very good therapy, but we have to be also careful about potential long-term toxicity. So for the timing, I'm sticking with the 4 doses, and you know, if they progress, then hopefully we'll have other drugs, which Dr. Walling kind of mentioned briefly coming up.
Any other thoughts from the NIH?
Yes, I agree.
Okay.
Dr. Shah.
This is a tough question.
Yes.
Can one receive PRRT after having previously been treated for acute myeloid leukemia and now begin a remission? Now, we know that one of the potential and the most terrifying long-term side effects of PRRT is getting acute myeloid leukemia. And the question is, in somebody who's already had it, are you going to potentially trigger a relapse that can be rapidly fatal if it happens? What would you do?
So in this particular case, again, this is a very rare scenario. You know, neuroendocrine tumors are rare tumors, and then leukemia in itself is not a very common blood cancer. So we are talking a very rare situation. However, the first leukemia happened before the PRRT use. It's probably has a different etiology. You know, the leukemia which happens secondary to the radiation exposure or the chemotherapy exposure has a totally different mechanism or driver mutations. So I would not automatically rule these patients who are treated in remission and cure and they cannot be treated with any myelotoxic agent. Prrt is another myelotoxic agent like any other chemotherapy, etc. So I don't think it's an absolute contraindication. We just have to be careful.
Okay, Dr. Zaks. I currently have a bovine tricuspid valve that needs replacement. How successful is the valve-in-valve procedure?
The valve-in-valve replacement after recurrence is a new procedure, so we don't have long-term experience with it. So at the present time, we can't really say for sure. I think if you ask me this question in another year or two, there will be enough cases around the country where we can make some comments.
Okay, and while Dr. Zaks has the microphone, I'll just give you a few more questions. What would you do with a patient who had severe tricuspid regurgitation on an echocardiogram but had no signs of heart failure? Fatigue was mild but not overwhelming. How do you make the decision about when the patient needs to have new valves?
So number one, you treat any evidence of right heart failure. The early signs of right heart failure are edema, which starts in the ankles. If it's not treated, it goes higher up the legs. If it's not treated, it reaches the waist, at which point you start to develop fluid in the abdomen called ascites. If it's not treated, it goes higher, and it reaches the level of the lungs, and you develop pleural and pericardial effusions. So the first thing you do is treat any evidence of right heart failure. The second thing is when you think you've treated it optimally, of course you repeat the echocardiogram. And the echocardiogram enables you to look at the pressure within the liver by looking at the inferior vena cava and whether or not it collapses normally when the patient breathes in and out. If it doesn't collapse, it means that the pressure in the inferior vena cava is high. That means the pressure in your liver is high. That means if they do any abdominal intervention, you are at greater risk of bleeding. Therefore, if they do plan on doing tumor reductive procedures, we recommend that you fix the heart before you proceed with abdominal procedures.
Okay. There's a question, what is the difference between small cell and large cell grade 3, it says aggressive carcinoid, but those types of tumors are not aggressive carcinoids. Those are neuroendocrine carcinomas. That's a different type of disease. Remember I said the grade 3s could either be neuroendocrine tumor or neuroendocrine carcinoma. The neuroendocrine carcinoma are the ones that are particularly aggressive, have very high Ki-67, that is typically more than 50-55%, and can range all the way up to 100%. They grow very fast, and they need to be treated typically with chemotherapy or sometimes immune therapy also. And they come in large cell type and small cell type. Small cell type and large cell type are just pathologic descriptions. There's some biologic differences between those two, but they typically both need aggressive treatment with similar sorts of regimens. Any other thoughts from Kentucky?
Yes, so these are high-grade neuroendocrine carcinomas. I would, although half of the name is same, neuroendocrine, but please don't confuse them. They're very different diseases, day and night difference, and they're very aggressive. In fact, the small cell carcinoma is so aggressive that the doubling time is almost 14 days, and we usually institute chemotherapy right away, just kind of like leukemias, while at the time of diagnosis, while the patients are in the hospital. So they're very aggressive tumors. The median survival is very, very poor. There have been some recent advances made in this kind of arena. In fact, I was at AACR last month, and there was DART data coming out from neuroendocrine carcinoma, use of immunotherapy ipi-nivo combination, and they had seen some benefit in these high-grade neuroendocrine carcinoma subset of population, but this is a small trial, needs to be validated. So we are making some progress, but these are unfortunately very aggressive malignancies and very different both at the molecular level and also in the terms of natural history disease progression compared to the neuroendocrine tumors.
Okay, next question. Can you have a net in the brain? The answer is yes. Neuroendocrine carcinomas of high grade go to the brain more frequently than others, particularly if they start in the lung. But lung that is not high grade, for example, carcinoid and atypical carcinoid of the lung, also go to the brain more commonly than intestinal ones do, and should not be a site which is overlooked. One of the things about brain metastases is there's a blood-brain barrier that prevents a lot of treatments from getting into the brain. And that's a potential problem because you could be treating other things in the body and the brain tumors are sitting there happily growing because the medicine doesn't get in. So you should be aware if it's there. There's specialized treatments. You can be treated with neurosurgery. They can be treated with targeted stereotactic radiation. And there are certain drugs like temozolomide, like the investigational drug cabozantinib I was talking about, actually gets into the brain also, and I've treated people with lung in that situation. And there are other situations as well. Intestinal carcinoids can go to the brain also, but it's just much more rare. It's rare enough that people don't normally do MRIs of the brain as a routine staging test, but would only do it if something turned up. And on the subject of brain metastases, a lot of people, when they get gallium scans, come out that they have increased uptake around the brain and totally freak. And most of the time, those turn out to be meningiomas, which are benign tumors on the surface of the brain. They're not in the brain, and they're benign. But they have intense somatostatin receptor expression and will even respond to PRRT when it's being used to treat other things. So you have to put it all in perspective. Any other comments? Okay. Let's see. So many questions here. Does gallium-68 only see tumors on the liver? No, it sees anything in the whole body, clearly, wherever there's a somatostatin receptor positive tumor. Could there be tumors in small bowel that don't show on gallium-68? Who wants to take that one?
Gallium dotatate scan has a very high sensitivity and specificity, close to 91%. However, no test is 100% sensitive specific. That means every test we have has a potential to miss out on smaller lesions. I think if the lesion is less than 3 millimeters, or 1 or 2 millimeter lesion can be easily missed. That's why we need our surgeons. They palpate the small bowel and then feel it out. So yes, gallium dotatate scan can miss a very small lesion. However, it is as good as it gets. 90% sensitivity is not bad.
Okay, is mesenteric fibrosis the same as adhesions? Basically, yes, it's all made of the same scar tissue. It's just we usually use the term adhesions when we're referring to people who don't really have cancer particularly, but it's exactly the same thing. They're basically synonymous. Okay. Should serotonin be limited in foods? I think we talked about that earlier, that you do not need to limit serotonin in foods unless you want to check your serotonin production by a urine 5-HIAA and do a urine 5-HIAA. If you do a plasma 5-HIAA, you just have to be fasting and you don't need to have any restrictions at all. But if you're trying to treat carcinoid tumor by lowering serotonin, you're wasting your time. It's like throwing a drop of water in a bucket all full of water. You're not going to see a difference because almost all the serotonin is being made by the body. It's like if you eat a little bit of cholesterol, it's not going to make your cholesterol level go up very much. It's the high saturated fats and other things that are making it really go up. So I wouldn't worry about eating a banana or a piece of chocolate or some walnuts or whatever if you have carcinoid. Now, if you have syndrome and you know that eating something is going to make a trigger for making your symptoms worse, that's different. But just in general, I would not put people on extra restrictive diets. People are already restricting their diets a lot because of just beliefs about what treats cancer and because of trying to eat low fiber for partial obstruction or other limitations. And then when you take away all the foods you like on top of that, you could be restricting yourself unnecessarily. going a little longer? Okay. Good. Okay, thank you. After diagnosis, which scans need to be repeated and how often? Well, that's a fairly open-ended question, and one that we really don't have any absolute rules about. There are guidelines and NANETS and ENETS and NCCN, and a lot of people have guidelines about what to do. But the bottom line is that you repeat scans often enough that you know if cancer is growing and don't let it get out of hand, on one hand. On the other hand, you don't want to expose people to excessive radiation and anxiety, which happens every time you have a scan. So there's a balance. But I would say in general, if somebody has metastatic disease, that the range is between 3 and 6 months, depending on the circumstances and how aggressive the tumor is. If people don't have any metastatic disease but have a risk, like you take out a primary tumor and there's 6 positive lymph nodes, then normally people do scans every 6 months for a while and then switch to once a year. But if somebody has metastatic disease, once a year, to me, is too long a time. Do other people have other thoughts?
At baseline for a new diagnosis, I like to get the first scan in 3 months, just to kind of learn the biology of that particular patient. And if the tumor is very indolent and I don't see any growth, then as like Dr. Wolin mentioned, I usually space them to every 6 months and then to a year based on individual patient. But the first scan I try to get somewhat earlier to see and get that tumor growth rate.
Yeah, I usually do it, yes, at around 6 months. I mean, it's possible depending on, I also like to look at the Ki-67. If I feel like the Ki-67 is a little bit more higher, maybe I'll do a scan sooner, but overall it's every 6 months, yeah.
If your ileocecal valve is removed, is sleeping on an inclined pillow a good idea? I'm not sure that that has any relevance because the intestines are kind of flopping around in different directions, and I'm not sure that an inclined pillow would matter. I haven't heard of that before. Does
Unless
anybody
the
else?
pillow is like huge and you're totally inverted. I'm kidding.
So, I don't know. That's one I don't have a good answer. Okay. How do we go about addressing insurance approvals if somebody needs a Gallium scan or other diagnostic tests? What is the best way to be sure they're getting approved?
I think if a brief statement of the clinical data is submitted in response to a denial, that might be successful. However, when it's not successful, then you need what's called a peer-to-peer conversation. A medical person from the insurance carrier will respond to a request to have a peer-to-peer. The first question I always ask is, what are your credentials? The most recent one was a family practitioner. And when he realized that I was going to hold him to a standard of care at the level of our team, he immediately responded by saying, I approve it. And I always make it a point of getting the name of the person. And I have gone so far as to submit a complaint, a formal complaint, to the Office of Professional Medical Conduct in the state of the insurance carrier when there was an adverse determination which was not up to standard of care for the patient, and that's highly successful. The other two things that are successful are copying the Attorney General of the state and the Insurance Commissioner of the state. When you tell them ahead of time that this is what you're going to do, if there's an adverse determination by a suboptimal peer, usually they do not want those types of complaints, and they will approve it. Now, there is one additional thing. You probably heard of Lori Todd, the insurance warrior. She has written books on this. However, many people can't take time to read a book on how to do the appeal. And so if you contact Lori for a very reasonable fee, she will guide you or handle the appeal. I had a patient with Lou Gehrig's disease, ALS, nothing to do with cancer. I called her, and by the next day, she had done the appeal, and it was successful. So remember the name Lori Todd.
Okay. Okay. So when your physicians are proactive and aggressive and being your advocate, it's the best. And that's unfortunately what it takes in many cases to get things approved. Because even when we have FDA-approved drugs for FDA-approved indications, insurance companies still routinely deny them, and we have to argue with insurance companies with the peer review, as you hear. Okay. The concept of a net expert and net center of excellence was mentioned earlier on. And here's a question saying, how do we define that? Which is a really, really good question, because we don't really have any good definition in America. In Europe, they have centers of excellence that are certified by the ENETs, by the European Neuroendocrine Tumor Society. They have to meet very, very strict criteria, and they actually get site visited by ENETs, and they have to prove that they meet all of the criteria. In America, it's much harder to get an approval for such a site under those particular ground rules because of the way medicine is practiced in America. It's a little bit more difficult. It's theoretically possible to be ENET certified in America. There is no American agency that can certify. The only American site that's ever been certified is University of Iowa. And the reason that it's so incredibly difficult in getting certified is that you have to have at least 90% of the patients at the center presented at the Multidisciplinary Tumor Board. I present essentially all my new patients in the Neuroendocrine Tumor Board, and some other physicians who are full-time do as well. But in addition, there are people in private practice, there are people who are, different surgeons in private practice, internists, oncologists, and they don't necessarily present every single patient that comes through the greater health system of Mount Sinai in the tumor board. So it's very hard to get that particular number. But just for example, but in Europe, if everybody with a neuroendocrine tumor goes to the 2 or 3 centers in the country that are neuroendocrine tumor centers, it's a much simpler process. So I think that it's not a concept that's been really clearly defined. There are criteria that different people have created. The Carcinoid Cancer Foundation has criteria for what constitutes an expert, and you could find, under Find a Physician on their website, you can find people that are listed as being experts, and other groups have tried doing this as well. But so far, there is no formal accreditation for a center of excellence. And I think that it's really, people have to decide what is most important to them. Because for some people, a center of excellence has lots of funding from the National Cancer Institute. For other people, a center of excellence has the greatest long-term survivals. In other places, the greatest center of excellence is having the most experienced physicians in multiple disciplines all talking to each other. And I like to think that a great center has all of these things at the same time. But it's really hasn't been formalized.
Yeah, one quick way to kind of quickly check on is just a quick Google search or go to PubMed.com and see if the particular physician or the physician scientist involved in publication research activities in the neuroendocrine world. I mean, that's a very easy way to quickly figure out, like if you type Dr. Volan, you probably see 200 papers, right? So you know that he's at least, so it's an easy way to kind of filter out whether this person is truly an expert in that field or not, which anybody can do. It's a quick Google search or PubMed.com. You can figure out their active publications.
Okay. Do you recommend fasting before biomarker testing? It's a great question also. Hasn't been really formalized. Some biomarkers are probably affected more by eating than others. If you have a choice, it's great to get it fasting and then you don't have to worry. Otherwise, some of them really absolutely require fasting, like a plasma 5-HIAA. You need to be fasting overnight or at least 8 hours or something like that to have a reliable number. But for other tests, it's very variable, and not clear. So biomarkers are not always done fasting, but I think it's a good idea when possible. I don't know how other people deal with the situation.
It's preferable, but a lot of time, a lot of our patients are traveling from far, they're driving, they have issues with dehydration, diarrhea, sometimes it's
You have to just do the best you can.
So what we recommend is if you have a morning appointment, fast overnight and just drink water until we draw your blood. Or if it's an afternoon appointment, eat a light breakfast and then just drink water until we draw your blood.
Is PRRT appropriate for non-functional neuroendocrine tumors? Dr. Del Rivero?
Yes.
Do you want to try that one?
Sure. I mean, yes. Usually, the way kind of like we have our treatment algorithm at the NIH is like depending on the tumor burden, the way we do it at the NIH, if it's low burden disease and the patient is not symptomatic in the metastatic setting, we just may start with somatostatin agonists. Now, if the patient has a larger volume of disease, but again, nothing that may cause any symptoms, we still recommend the PRRT. And in order to control the symptoms, in this case, we can always use the other somatostatin agonists like lanreotide in combination with PRRT or other medications as well for the symptoms.
Okay. How often do you recommend getting a Gallium-68 scan? I think we talked about that a little bit earlier. My feeling is in everybody who's newly diagnosed and everybody where it's going to make a difference in therapy, right, especially if you're thinking of starting a somatostatin analog-based treatment. But using it as a routine surveillance is pretty highly selective for patients where you can't see the disease well on other treatment modalities. Okay, and I think we all agree on that. Okay.
I do want to add one quick point. So a CT scan, I think it was previously mentioned, is the dye we give, the iodinate dye we give is very nephrotoxic, sometimes with the borderline renal function, so we cannot do a routine CT scan IV contrast. The gadolinium scan with the dye with the MRI is a little bit better, but sometimes the kidney functions can be really bad that even MRI or GAD cannot be done because it has some chronic skin toxicity related to MRI as well. Net spot in those cases can be helpful because it is not nephrotoxic at all, at least the dye we give. So that again, it's very case by case basis, not a routine follow up or surveillance scan, but can be used and have the.
Okay. Why does the low serotonin diet restriction last 2 to 5 days, depending on the different lab requester? I presume this refers to restricting serotonin foods if you're doing a urinary 5-HIAA collection. And I don't know why anybody would recommend starting 5 days before when you do a perfectly good job starting 2 days before, which has become the national standard and official recommendation. So I think if you're going to do that, you might as well start 2 days before and the day of collection. But again, if you're doing a plasma 5-HIAA, the only requirement is a fasting blood, and you get the same type of information about 5-HIAA. And it's a little easier on people. Okay. Some of these questions are a little similar to what we've already discussed. What should be the frequency of a transthoracic echocardiogram if your serotonin level is greater than 1,000?
So I would get a baseline study. If there's no evidence at all of any fibrosis or any evidence of carcinoid heart disease, then I think if I wasn't sure how long the serotonin was high, probably I would repeat it in 6 months. And then if I saw absolutely zero, I might consider going to annually. But it's worrisome with a high serotonin level.
Right. And I think it still is worth checking 5-HIAA. I know there are differences of opinion, but especially now that we can do plasma 5-HIAA, which is so user-friendly, my procedure has always been to get a plasma 5-HIAA and plasma serotonin at the same time. And sometimes those two things are complementary, and sometimes you'll get a little bit more data points that can help explain things. One of the reasons why urinary 5-HIAs have been so difficult to do is they're really awkward. You can't, patients come from a distance, some people fly in. If you try taking a urine on an airplane, they'd lock you up for being a terrorist. I remember when the rules first went into effect, before they got as strict as they are today, they had a rule that you could take a liquid on an airplane if you can drink it to prove it was drinkable. That was the initial version. And there was a 20-something lady with a jug of urine, and it said on the bottle, acid bottle, and for the 5-HIA collection. And this TA agent said, throw it out or drink it, and started yelling at her. And she started crying, and she went crazy, and she said it was so hard making this collection, and she was flying in. So anyway, it's just so much easier doing the blood. But if you do the urine, you have to figure out how to do it.
I have a quick question for you. Do you like to monitor pro-BNP in these patients, especially if they have developed the cardiac dysfunction?
I used to do pro-BNP. I'm now doing BNP. And there are pros and cons. I personally feel that it is quite a sensitive marker for heart failure. And I am worried if I'm treating a patient for heart failure, if I cannot get a normal BNP, it means I have to look again and see, can I do a better job? So I think it's an excellent test.
Very good, thank you. Do SSRIs, these are drugs that are used for depression, work against serotonin cancer levels? Actually, they don't do very much for the serotonin production in the body. They work on the serotonin levels in the brain and raise the serotonin in the brain. Most of the time, you can actually use those same medications, even when people have carcinoid syndrome, although everybody is afraid to do it because occasionally somebody will have a worsening carcinoid syndrome or even a carcinoid crisis. But a lot of people can actually get away with it. But the tryptophan hydroxylase subtype in the brain is different than that in the body that's made by the carcinoid tumor cells. And you can, and it certainly does not treat the high serotonin causing carcinoid heart disease and carcinoid syndrome. It's not a treatment. If anything, it makes it worse, not better.
So I have seen, I think, 2 patients now who were not carcinoid patients, but were on very high doses of SSRIs, having serotonin syndrome. So, but in carcinoid patients, we have had many patients on SSRIs with no problem.
Right.
There's also an old study from Dana-Farber. One of my patients asked me the exact same question. There is an old study from Dana-Farber, and basically they concluded that patients being on SSR didn't really impact, carcinoid syndrome, so it's basically safe to take it. It wasn't a prospective study; it was a retrospective study, but at least there is some data, that it's safe. And I personally have never seen any issues with SSRIs in my patients.
Okay. Dr. Hughes said there are things you can do to slow fluid coming to the colon when you no longer have the ileocecal valve. What are those things? Well, Dr. Hughes isn't here to directly address that, but typically people use bulk agents and things like Metamucil to absorb some of the water and help during that period of healing. It's always a challenge when people have multiple causes of diarrhea post-operatively, and if you can treat any of the specific causes of diarrhea, it's terrific before you just attribute it to healing after colon resection, because all of the things we talked about before can still be happening.
So tincture of opium can also be added to the treatment for diarrhea. And I've used it quite a few times, and it's highly effective.
Okay. What do you do if your ileocecal valve is not working properly and feces are backing up? Do you need antibiotics for life? I think that's really needs to be addressed to a gastroenterologist, but normally a medication which is a non-absorbed antibiotic, is used for a period of time, and you don't have to continually take it forever and ever and ever. You just use it to treat problems. But there's some people with multiple relapses, and what kind of suppressant medication should be used should really discuss with your gastroenterologist. What is the best way to reduce histamine? Presumably histamine produced by a neuroendocrine tumor as one of the hormonal type things made by a tumor, in addition to all the other treatments that we've talked about with cytoreduction and somatostatin analogs and everything. Antihistamines are a specific treatment, and you could add antihistamines to the regimen, and it does help. Okay. Can you address the status of the ADVINS test that is being conducted in Sweden?
Never been to Sweden.
I have. It's a nice place. Can PNET status post-Whipple result in episodic neurologic issues such as weakness, difficulty walking, and talking? Can anybody think of any way a Whipple operation would have any relation to that at all? It's probably unrelated. Probably unrelated is the consensus. Okay. Anything we haven't dealt with? Prolonged surgeries to prevent nerve damage. Can you do electrical stimulation throughout the surgery with wires stuck all over the body?
I'm not aware of the scenario, but nerve stimulation's been helpful in cancer-related pain management in select cases. But this is not the scenario where we usually refer them.
Okay. There's a question about the NET test, which is a new biomarker, which is a molecularly driven biomarker that's being used now, and it looks like it may have significant utility in PRRT. They're doing that at Memorial Sloan Kettering as a quite routine treatment to help manage PRRT patients, and all around it's being studied for sure and being used. Yeah.
Yes, so there were a couple of abstracts, posters, and e-nets from their group, actually 4 or 5 of them. So they have small data and all of these are coming from individual institutes. So again, keep in mind that this needs to be validated in a larger subset. But they believe that this blood-based biomarker test can help predict who's going to respond to PRRT or not, who's going to relapse down the way or not. And this particular blood test kind of detects certain proteins circulating the blood, certain RNA circulating the blood, which are related to neuroendocrine tumor, and supposed to be very sensitive in detecting these tumors. Again, I personally do not have experience with this test. We are going to start using it in one of our clinical trials, an exploratory biomarker. It's very new. It's definitely not ready for prime time yet.
That is all the questions. We did get through them, and I want to thank everybody for being here. Yes.
I just wanted to make one comment about Zermello, since it's coming into more and more frequent use. And that is that a warning about the use in that it can cause constipation is a very important warning. But I want to pass on the message that the appropriate response is to stop using the drug immediately if constipation develops, wait until the constipation resolves, and resume the drug at a lower dose. I now have a patient controlled on a half a tablet a day. And so I would not give up on the drug, especially if your serotonin is elevated.
Thank you.